Okay, guys, I'm trying to find where we stopped. Implementation and evaluation. So, going to go over some interventions that we're going to do for our patient for fluid volume problems, for electrolyte problems, or acid-base balance problems. So first of all, we're going to start with IV therapy. So IV therapy is considered like giving a medication, so we need to do our 6 rights. That would be the right patient, right solution, or drug or medication, right rate, which would be our dose. The rate is what we're programming into our IV pump, so our cc's per hour. The right route, which of course is IV. The right time, so we are starting our IV solution at the right time. We've selected the right rate, so it's running in and it's finishing the fluid at the right time for us to start our next bag at the right time. And then of course the right documentation. Oops, let me get back to this view, I think. So there's several advantages to using the IV route. Of course, it's quick, immediate access to provide fluids and electrolytes. It's a great access to give medications IV where they work faster. We get to our therapeutic level quicker. We could provide total parental nutrition through an IV site and administer blood products through IV. So this is going through the 6 rights: the right patient, the right solution, the right rate, the right route, of course, and then the right time and right documentation. Okay, so on page 1013 goes through different types of IV solutions, that little table, so you can refer to that for easy studying. Okay, so basically there's 2 types of IV solutions: crystalloids and colloids. Crystalloids are basically all of our IV fluids. Colloids are like blood products or something like that. Okay, they have crystalloids have small molecules or electrolytes that pass easily through the cell membranes, whereas colloids do not, and they stay in the vasculature. So crystalloids again are our fluids, and colloids are blood products or some form of fluid that beefs up blood volume but doesn't leave the vasculature. Okay, so there's, as far as crystalloid solutions, so there's hypotonic, isotonic, and hypertonic. That refers to, so the solutes in the solution, is it less than blood plasma, so it would be hypotonic? Is it the same as blood plasma, or is it more than blood plasma, so it's hypertonic? Okay, so this table on page 1013 does break down the different kinds of fluids that we give according to hypotonic solutions, isotonic solutions, and then hypertonic solutions. Okay, all right. So hypotonic fluids have, again, lower osmolarity than blood. So when we give those solutions IV, that could cause a fluid shift into the cells, right? So it's basically kind of, if you can kind of think about it, it's going to kind of dilute our blood volume, or our blood, not blood volume, I'm sorry. It's going to dilute the solutes in our blood, okay? So we're going to have a lower osmolarity in our vasculature than in the cells. So our water will want to go to the cells to kind of try to even our osmolarities out, okay? So if we're hypernatremic, then we are going to see fluid shift, okay? If we use these solutions, and then when we fix our problem, then we need to discontinue these solutions. If we continue to run these solutions, then we're going to cause another problem, okay? So if we continue with the hypotonic solutions, then we're making our blood, the plasma in our blood vessels to be hypotonic, okay? So we're going to keep dumping fluid into the cells, so we're going to cause intracellular swelling and water intoxication, and so those cells won't function correctly. Now in the brain, like, this could be a really huge bad thing, and cause the brain cells to swell and cause increased intracranial pressure, which would be very devastating to a patient, okay? So that was hypotonic solutions. Isotonic solutions are very much the same as blood plasma. So when we give these fluids, we're just basically going to be increasing our intravascular blood volume. We're not going to be causing any shifts into or out of the vasculature or the cells, okay? But again, like, even though this is isotonic, we still don't want to be dumping a lot of this in there, because even though we're not going to be changing or having any fluid shifts, we're going to keep growing our blood volume if we keep running these fluids, so we could cause a circulatory overload. Hypertonic fluids have higher tonicity than our blood plasma, so when we give these fluids, we're going to again increase the osmolarity in our vasculature and start forcing fluids out of the cell and into our bloodstream to kind of dilute that hypertonicity in our bloodstream or in our vasculature, okay? And so if we keep pulling fluid out of the cells, when we correct the problem, we need to stop this fluid. If we keep going with this problem, if we keep going with this fluid, we're going to create yet another problem, which will lead to, we're pulling all the fluid out of our cells, so we're going to have cellular dehydration, and we're pulling that fluid out of our cells and putting it in our vascular system, and so we're going to cause a circulatory overload. Okay, now the colloid solutions, I touched on these a little bit. So these solutions contain more protein or starch. So these particles, they remain intact in solution, so they don't dissolve and they can't pass through the capillary membranes. So basically they are used to increase our blood volume, okay? And so examples of those would be our blood or blood products that we might get, but it also could be albumin. So you remember we talked about albumin and how albumin is a protein that holds on to water in the vasculature. There's a couple more products that we can use, dextran, plasminate, and hetastarch. So we can use those in addition to blood products to help beef up someone's blood volume, especially someone who might be having a problem with a bleeding issue. Like we have used, I think we have used plasminate, but I know we've used hetastarch in C-section OR where we've had a patient that's having a bleeding issue. Okay. Now another thing we can do with our IV fluids is we can provide glucose in our IV fluids. So maybe we have a patient that for some reason we're not allowing them to eat, but we want to make sure that we keep their glucose levels up. We could give them a solution that has glucose in it, and that comes in the form of dextrose. It's usually in 5% or 10% concentrations. So anyways, you could have, so if you look in your book on that table, so like any of your, just about any of your solutions that we give could have a little bit of dextrose in it. So There's an example is D5, dextrose 5%, in quarter percent normal saline. We could have lactated ringers with dextrose in it. We could have half normal saline with dextrose in it. So the doctor will definitely order which type of fluid he wants and how much dextrose he wants. But typically, unless someone has a blood sugar problem, typically we give D5, okay? So that's the patient that's NPO for a while, and we just want to try to give them a little bit of blood sugar, but anything higher than that, usually in concentrations higher than 5%, maybe they do have maybe a little hypoglycemia problem in addition to whatever else is going on with them, okay? So here's some fluid choices. So we have normal saline, which is 0.9% sodium chloride. That's an isotonic solution, okay? We use that just for a fluid replacement. And normal saline, we call this normal saline. We don't usually say, oh, go get me 0.9%. We just, in nursing and in the units, we say, go get a bag of normal saline. But the one thing that you need to remember about normal saline, or one thing you need to remember about giving blood transfusions, is normal saline is the only solution that you run with blood transfusions, okay? So just remember that, and life will be good, which we will be going over blood transfusions in lab. So there's different amounts of different amounts of sodium chloride, ranging from actually 0.2%, but 0.33% to 3%. So depending on what your doctor orders, that's what you'll do, okay? So this is how you know whether or not it's a hypertonic or hypotonic solution. Remember, I said that normal saline, 0.9%, is an isotonic solution. So therefore, if you're using something that's more than 0.9%, then it's hypertonic solution. If you're using anything that's less than 0.9%, like up here in this first sentence, 0.33%, then it's a hypotonic solution. All right. Okay. So lactated ringers. This solution contains sodium, potassium, calcium chloride, and lactate. And it does resemble blood plasma very well. It has a few more electrolytes. It is the fluid of choice in the OB world. That's all we use is LR, unless we have a blood sugar problem, and we'll use a dextrose 5%. It says here that they use this a lot following surgery. I don't know about surgery unless it's a C-section, but we always use LR in the labor. We call it LR, lactated ringers, or you might hear it someone say, go give me some ringers lactate. Okay, so it just has a few more electrolytes in it. That's explaining those a little better. Now, so we've decided, or we haven't decided, the physician has ordered what type of fluid they want us to use, and now we need to get an IV started on our patient. So, and the site that we use is up to the nurse. She's the one that's going to be doing the peripheral stick to get the IV started. So we try to find the best site in order to do that, okay? So if we need to, if we need to run high volumes of fluid, we want to make sure that we have a larger vein. If we're having very hypertonic solutions, we might want a larger vein. They take those solutions easier without irritation. If we use little tiny veins and try to pump in large amounts of fluid, those little tiny veins just don't flow, won't let that much fluid flow. And those little tiny veins, if we have a lot of solutes in our fluid, like that's going to burn a little bit and cause a lot of irritation to a little tiny vein. So we need to select the best site. Now, also when you're selecting a site, you want to select the most distal site first. So if we're talking about someone's arm, okay, we want to try to use the veins farthest away. So that would be the veins in the hand, okay? So if you use those veins for a few days and it's time to change your IV, you can go down the arm a little bit, below the wrist, and use that site for a few days, and then go up the forearm and use that site for a few days, and so forth and so on. If you start midway up the forearm or in the antecubital spot and use those veins, then anything below those veins or going towards the fingers will not ever be an option for you. Well, I don't want to say never, but the chance, if you've used the antecubital site for your maximum days, so most places it's 72 hours, then the integrity of that vein at that point could be diminished. Okay, so if you think about going to a vein below the antecubital, that area may work just fine, but then when that infusion starts flowing up towards the antecubital site, that the integrity of that antecubital site may be diminished, and there might be problems at the antecubital site. So I hope you can understand that. If I explain that confusingly, then ask me. But you want to start at the most distal site and then work up the arm. You want to avoid the wrist and the elbow region. Well, because they bend, and if they bend, they could occlude or kink off your catheter that's in your vein, okay? And then you can't use any venous sites on a surgical limb. So if a woman has had a mastectomy, or if she has grafting, or if she's had oh, sorry, it's escaped me. Hold on. If the lymph drainage, if there was some surgery in her lymphatic system and that arm, you can't use it because those places don't drain. It's just not a good thing to do, okay? Other considerations are the age, the diagnosis, the health history, the condition of the veins, okay? For instance, as far as age is concerned, like in the neonate or the preterm baby, so peripheral IVs are very difficult. Sometimes the scalp is the best place to do peripheral IV site on a premature baby. Sometimes the foot is the best site on these babies. Sometimes we need to use the umbilical vein for IV site. Anyways, like an adult or an old person who has poor peripheral vascular circulation, like we wouldn't do a foot or ankle vein on them because we know that blood flow is not great there to begin with, okay? So anyways, here's a diagram of all the different veins that we could possibly be using in a person's hand and arm, okay? All right. Now, we also need to try to determine what size needle that we want to use. Now remember, gauge tells us the diameter of the needle. The smaller the gauge, or the smaller the number, the larger the diameter. So it's kind of different. So a 16 or 18 gauge, those are huge diameter IV catheters, okay? And we would use those when we need to put a lot of volume in quickly into a patient. So 18 gauge is the standard gauge that we use in OB because pregnant women who deliver are at huge risks for bleeding because they do bleed after delivery, and we're just hoping it's a normal blood loss. But if it's not a normal blood loss, like if they start hemorrhaging, we need to get lots of fluids in and maybe even blood in. So we need a big catheter. Or the gauge needs to be a large diameter catheter, and so the larger the diameter, the smaller the gauge number is, okay? So a 22 gauge, that's for a person that we're not really anticipating any type of emergency type things. We're just doing some infusions. We can do blood transfusions in a 20 or 22 gauge, but I'm telling you, your hospital policy is going to probably say like 18 gauge for blood transfusions, period. And the only time you would use a 20 or 22 gauge blood transfusion is if you absolutely could not get the 18 in. Otherwise, they're too risky. Okay, blood transfusions, like blood is a thick, viscous, not viscous, but a thick, it's not just like water going in there, okay, so it needs some room so that it doesn't get clogged up or clotted off, okay? And then if we needed to put that blood transfusion in fast, like doing a 20 or 22 gauge, it would probably not cut it, okay? And then a 24 gauge is what we would use on children, infants, and the elderly who have very tiny, frail veins. Okay. All right. Okay, so we select the size of the IV we need. The catheter. So there's also the length of the catheter, and a standard length. Standard length is 1.5 inches, I think. So that's just the standard. Like the smaller the person, the smaller the length. Okay. So we select our site, and then peripheral IVs. All peripheral IVs are, well, not all. The ones that we put in, the little IVs that we put in the arms, those are over the needle catheters or angiocaths. Okay, so basically what that means is there is that little needle that we use to puncture with, but over top the needle is the catheter, that little soft, flexible catheter. Okay, so once we get into the vein, all right, we thread the catheter off the needle and into the vein and then pull the needle out. Okay. The needle is what they call the stylet. All right. Now, there's a couple other types of peripheral IV catheters, and the winged infusion needle, or they call them butterfly needles. These are the really small diameter, so your 24s or 26 gauge IV catheters. They have little, and I'll have to show these to you in lab, they have little plastic wings on the side for you to hold, the nurse to hold as you're trying to insert these. We'll just have to show you these, okay? So once you see these, you'll be like, oh yeah, I see how that could be called a butterfly. The next one, midline catheter, used for longer IV therapy. These are like 7 to 8 inches long. I've never really used these. I will tell you what we use instead. Okay. So your central venous catheter. So these go right into, usually these go right into the superior vena cava. Okay. All of these except one need to be placed by a physician. One of them can be placed by a nurse, and she has to be a specially trained nurse. So a central venous catheter, it allows large infusions We can use just about any type of solution in there without worrying about hurting the vein. And then, in addition, it also allows us to continuously monitor venous pressures. So that's a great thing for these really super sick people in the ICU. But here's 4 different types of central venous catheters. The non-tunneling, the peripherally inserted one, or the PICC line, and these are the ones that specially trained nurses can put in, the tunneled, and the implanted port. So we'll kind of review these really quickly. I do have a lot of information on these, but I'm not going to spend a lot of time on these because we do have a guest speaker coming tomorrow to explain central venous catheters a little more. Anyways, the non-tunneled central venous catheter. So basically, tunneling means that. Non-tunneling means that it goes directly into the vein. Okay. And then threaded in through the vein. The tunneling kind means that part of this tubing is tunneled or burrowed underneath the skin for a distance, and then it cannulates the vein. So we'll see some pictures in a minute. But anyways, non-tunneling central venous catheter. It says requires short-term use, and yeah, this may be 3 or 4 days, or short-term use could be a weekish or so. But they're getting a lot of IVs, okay, and some maybe toxic ones, some TPN, total parental nutrition, maybe receiving some blood products or whatever, okay. So a physician needs to put these in. They have what they call double or triple lumen. So basically what that means is, so this is a catheter that has like 2 or 3 different catheters in it, sort of, okay? So we'll see some examples of these. But anyways, these lumens, these extra lumens, they allow us to run fluids that are incompatible with each other without causing a problem because they're not going through the same tubing, okay? So you remember when we practiced last week in lab where I said you need to make sure, you could run multiple IVs, but you need to make sure all the IV solutions are compatible in a peripheral IV, because otherwise they will precipitate and cause a bunch of problems and be all bad and hurt the patient. But in these central venous catheters, you can run fluids that are incompatible, okay, because of these different lumens, all right? So the PICC line is inserted peripherally, so in the arm, but it does extend up to the superior vena cava, okay? So these are super long, all right, and specially trained nurses can put these in. These can stay in for a long, long time. So when we talk about, so one of the uses for this for long-term use is we use this in OB. So I don't know if you've ever heard the term hyperemesis gravidarum, but that is when a pregnant patient has a problem with vomiting, nausea and vomiting beyond morning sickness. So this patient basically has nausea and vomiting in such a severe form that they cannot in any way, shape, or form tolerate anything in their mouth. They can't drink water, they can't drink sips, they can't drink ice chips, they can't eat, and this lasts for weeks. This is not just your typical morning sickness where you get up in the morning and you vomit and then the rest of the day you're fine. These people are vomiting all day long. They can't keep anything down ever, forever and ever, however long it lasts, and it lasts for a long time. So we put PICC lines in these people and provide them parenteral nutrition through a PICC line because they cannot eat, okay? Anyways, so that's about the PICC line peripheral IV. So here is your threaded central venous catheters. These are the tunneling ones, okay? So they go through the skin for a while and then they get to the vein, okay? So we'll see a picture of those Anyways, no matter which kind of, oh, and then the port. Let's talk about the port. So the port is kind of weird. The port is basically a central venous catheter, okay? But the catheter, instead of exiting the skin through a tube, and then you have this tubing, there is this little port, or this little, for lack of a better word, a little box underneath the skin, okay? And the central venous catheter is connected internally to this port into the vein. So when the nurse accesses this port, it's basically this lump under the skin. She can't see it. She can't connect to it. She has to penetrate it with a special needle, okay? And she penetrates it with a special needle. She runs the fluid or medication in, and then when she's done, she pulls the needle out. It's this little port underneath the skin. So hopefully we can show you a picture of that, or show you that in lab. I should try to find a picture, but anyways, so here's an example of a tunneling central venous catheter. So you can see in this picture how the catheter is in the superior vena cava, okay? It exits the subclavian vein, and then it's under the skin all the way to right there below the right nipple. That's where it exits the body, okay? So that's a tunneling one. All right. Documentation concerns, of course, we need to document the site. We need to say what size needle we've used. We need to say whether it's patent or not, what solutions we're using, how the dressing is, the assessment of the site, and all those things, okay? So these next slides basically are going to walk us through starting IV fluids, which we kind of did last week in lab, because I felt like we were going to have way too much to do this week to just go over starting IV fluids. So that's why we did it last week. But anyways, so of course we gather all of our equipment. We check to make sure that we have the right fluid. We check to make sure the fluid looks good. We check the expiration just like we do on meds. We get over our equipment. We choose the right bag volume, whether we need bag volumes are anywhere from 50 mLs to 1,000 mLs, okay? So we get the right amount of fluid, we get the right type of fluid, we get our IV tubing and all of our things, and then we spike our bag like we did in lab class. So I'm just going to kind of run through this. The one thing I do want to point out to you is, so there's this thing called drip factors. So where that spike is that we put through that little canal in the IV bag, so where the fluid drips into that little chamber that we filled halfway with fluid before we primed our tubing, so the drips that come out of there, so there's different drip factors. There's the 10, the 15, the 20, and the 60. 10 is the normal drip factor, okay? But 10, 15, and 20 are called macro drips, and the 60 is called a micro drip. Now, when it talks about drips, it's talking about drips per ml. So when it says 10, that means that it would take 10 drips to equal a whole cc of fluid, okay? 15 drops would equal a cc of fluid. 20 drop, the same. Now a 60 drop, 60 drops just to equal 1 cc. So that's a micro drip, okay? So so we always just use the 10 ml drop tubing, but some places like in PEDS or in a NICU, they might use the 60 drop per ml. So they're just this very tiny drips, okay? So, but usually you'll use the 10 unless directed otherwise for the medication. This talks about our secondary ports, which we discussed. We don't have a lot of glass containers anymore, so that would be like an actual glass bottle that has a little port on the bottom of it that we would spike with our IV tubing. When we use a glass container, we need it to be vented, okay? So you know that when you're sucking on a bottle of something and it makes that sound when you let go of your suck, that just got vented, okay? So a glass container needs a vent. It can't collapse as fluid and air are being withdrawn from it, so there needs to be a vent. I don't know if there's any glass containers anymore, ever anywhere. I used to use them back in the day, but I haven't seen any for a million years. So usually we have the bags like we used in lab, and that's why we burp those, is to get that air out so that if for some reason our fluid runs through, that we don't now have air running through our tubing, okay? Converting between a continuous and intermittent, very simple, disconnect your tubing. Usually the IV catheters that we put this little extension down by the IV catheter that has a nice easy port that we can disconnect IV tubing to, and we can flush it, we can put medications through it. It's a nice little port where we can connect tubing and disconnect tubing. It makes it very easy, so we'll show you that again in lab. So we document our patency of our line, the date, the amount of the flush. We make sure we date everything so that the next nurse coming can look at the date and make sure, one, does this IV site need discontinued and restarted, or does this tubing need discontinued and I need to grab new tubing. So some fluids have different lengths of time that they can be in tubing without the tubing being changed. The hospital will have policies on that. Flushing IV lines. So when we have an IV that is on continuous IV fluid, like, we don't need to flush because the fluid is continually flushing through and keeping that IV site patent. However, if we don't have continuous fluid running through, so we just have an IV in the person's arm and it's just capped off, that's called saline locked. So it's just capped off, and then we do need to flush that usually every 8 hours with saline to keep that IV catheter that's in the vein patent, and so that it doesn't clot off, okay? So then we need to document that. Now this is a volume control device. Usually this is not used so much anymore. It's used a lot in pediatrics. Some pediatric units have policies where you have to use this volume control device if you have IV fluids on a pediatric patient. So what happens is, not only are you programming your pump with volumes, you're only putting the volume from the IV bag in this little chamber that you're going to infuse each hour. So then each hour you have to come in and refill this volume chamber, okay? And the reason why they do that is because a pediatric patient, we can't fluid volume overload those people. Actually, it's very easy to fluid volume overload those people. So this is a safety mechanism, okay? In addition to programming our rate on our IV pump, okay? Infusion rates. So infusion rates are usually programmed milliliters per hour on the pump, or ml per hour, okay? And so the doctor will determine what that rate is, and we just program it in there, okay? So we talked about the infusion control device being used on the pediatric unit. Okay, so let me look through here. So we use electronic pumps 99% of the time. You can infuse a continuous infusion without an electric pump. Then we would go back old school and count the drips and count how many seconds those drips were and try to calculate an hourly rate. I used to do that all the time back in the day, and it took forever. So anyways, we can always infuse fluids without an electronic pump. However, there are fluids that you absolutely cannot do that to because they need to be exact rates. So you do need a pump for those types of fluids, and that could be antibiotics, that could be that magnesium sulfate that I talked to you about today in lecture, Pitocin that we use on pregnant patients, and dilantin or digoxin, so the medications that you use in ICU. I'm sorry, I don't know what they are, but those are, you know, very dangerous drugs, and they need a precise infusion rate. So some things you have to have an IV pump for. Okay, so basically this is all the same. So we program the infusions. We control the gravity. So if we're not using a pump, fluid is going in by gravity, and it's we're adjusting that little roller clamp. So we can show you that again. Okay, infusion rates. Still, we're on infusion rates. All right, so we need to use an electronic infusion device for these patients. Okay, so we talked about that. So we need to use careful aseptic technique when we're dealing with our catheters, when we're hooking up our IVs, when we're giving medications. We need to clean with alcohol and all that stuff to prevent infection. Other complications are, you know, occlusion, so like our vein clotted off. Phlebitis, which is inflammation in the vein. So we've used some medications or fluids that irritate the vein, or we've kept that in too long in the vein, and the vein is finally given up and saying, I've had enough, and so the vein gets inflamed. Infiltration is leakage of a non-damaging fluid into the surrounding tissue. Okay, so basically what that means is fluid has left the vein. It's seeping out into the tissues, the interstitial space, but it's not causing damage to the tissues, okay? It's not burning it. It's not damaging those tissues. Extravasation is the opposite. It is the leakage of fluid that is damaging the surrounding tissues, okay? So we need to assess our sites for both of those things. All right, when caring for a patient receiving IV fluids, medications, or both, so we need to verify our orders. We need to make sure that the correct solution is infusing at the right rate. Make sure that drip chamber is half full and the IV is dripping before we walk away. We need to make sure our tubing is not kinked. We need to make sure we check the date on the tubing in case it needs change. We need to make sure the dressing is as clean, dry, and intact, and that we check the date on the dressing. We're supposed to write the date and our initials and put it on the dressing, and then that tells us whether the dressing needs change or whether the IV needs changed. And then IV solution rate, tubing, and insertion site are assessed every hour. So when I put on our checklist how we go in and check IVs every time we round on our patient, we're checking that everything is going okay with the IV. Okay, so basically it is assessed every hour. Let's see, so depending on the type of infusion, how frequently do you need to change the tubing? So the hospital will have a policy on that. So usually every 72 or 96 hours. Usually I'm used to every 72 hours. Blood tubing needs changed every 4 hours. IV with fat emulsion needs changed every 25 hours. TPN needs changed, what did I say, 24 hours. TPN needs changed every 24 hours. If it's without the fat emulsions, it can go up to 72 hours, okay? So depending on what you're running, make sure you check your hospital's policy and document, okay? So central venous catheter, so you know, we're going to be doing the same things to the central venous catheter that we've done with the IV catheter, except for a few differences. So tubings need to be changed more often. Dressings need to be changed more often. It's a sterile dressing change for a central line. There's no site rotation because these are a little bit longer term use, and the doctor is the one who needs to be doing that, okay? So we already said the PICC line is for longer term use. Let's see. Transparent dressings we usually use on just about everything, so we can make sure we can assess at the site. So this transparent dressing covers the site, and then we can still assess it, okay? Document. Now when we're flushing IV sites, well, the PICC line in particular, so we flush things to keep them patent. And then like for the peripheral IV, if we're flushing it and it doesn't want to flush, like we can't get it to flush, then we might just need to tug a little bit on the IV. It might be resting up against the vessel wall. But that's the same thing with the PICC line, so it could be you know, resting up against the vessel wall. So if we just kind of reposition the patient, it usually flushes pretty well. Okay, blood administration, we're going to go over that in lab as well. We need to run what kind of fluid? Normal saline, of course. Now, when we do run blood, it's a big deal. We've got to stay there with the patient for the first 15 minutes. We've got to assess vital signs. We've got to instruct patients on adverse reactions so that they can report those to us. And then, so the possible reactions are hemolytic, allergic, and febrile. Okay, so a hemolytic reaction is we've given the wrong blood to the wrong person, and like we talked about in class today, then that causes a hemolysis or a destruction of red blood cells because our antigens don't recognize the antigens in the blood, so we need to make sure that we give the right blood to the right patient. Okay, allergic reactions, so the patient can be have an allergic reaction or a sensitivity to the plasma proteins in the donor blood. So depending on how severe those are, we may need to stop and treat the patient. Febrile reactions, so basically depending on what kind of blood product we're giving, we might be reacting to the white blood cells, platelets, or plasma proteins, and it causes an increased temperature in the patient. Okay, so we would have to treat the patient, stop the infusion, and try to flush their system out. Okay, so with all these reactions, you know, we may have to stop the infusion. So, you know, the hemolytic reaction, definitely got to stop it because we're giving the wrong thing. and then treat the patient and then try something different, okay? Document, document, document. So when we're given blood products, there is this whole form we need to fill out. We take vital signs before we start the infusion. We stay with the patient for 15 minutes. We retake the vital signs at 15 minutes. And then if everything is okay, then we can leave the room and continue doing other things and then checking on the patient. And then when the transfusion is completed, then we do another set of vital signs on the patient. But remember, we're instructing the patient regarding those transfusion reactions and to alerting us if they are feeling any of those things. There's this whole documentation procedure that we have to go through. We need another nurse there to verify, so we need to check the patient's band. We need to check the blood product information. We need to check the blood band information. There's just all kinds of things we need to do. And when we start taking care of patients who are getting blood products, we will go over all that paperwork and stuff in the facility. But it's a big deal, and there's lots of checks and double checks when giving blood. Total parental nutrition. So there is a lot of good stuff in this fluid. So it's a hypertonic solution. We give this for patients to meet their nutritional needs because they, for some reason, are not eating for whatever reason, okay? Usually this is through a PICC line or a central venous catheter or an implanted port. It's not given in a peripheral, just a peripheral IV, okay? So here's all the things that can be in TPN. We're providing calories. We're keeping the patient from wasting away. Here's all the reasons that we might be giving, indications for TPN. So their illness is a long illness. They're not able to eat. They've lost more than 10% of their body weight. Their albumin levels are low. Whatever the doctor thinks, he'll order this TPN, and he will actually order what amounts of things he wants in it, okay? When it's to be infused and all these things. So Phyllis McCarthy is going to come talk to us about TPN, and you guys are also going to get the opportunity to go to Hillside, to help her with her patient who gets TPN. So this will be a great learning experience, okay? So a lot of complications associated, could be associated with TPN, so we need to really be monitoring these patients well as far as their lab values and their blood glucoses, their input and their output. We need to be, of course, assessing the actual site that we're putting this in to make sure that there's no complications with it as well. And then what? Document, document, document. Recording our INO, so our input and output. Definitely want to monitor that. So, of course, with evaluation, once we've provided our interventions, we're evaluating to make sure that they're going well. If they're not, we need to change things up. There's all kinds of different things that we use for evaluation as far as in our assessment parameters. And those could include, lab tests as well. So we might need to change our plan. So I think that's it. Yes, it is. So I hate recording and not knowing if you guys have questions. So please, if you have questions, please jot them down and let me know the next time we meet.